thrombolytics, and antiplatelet drugs. So this is going to be a very boring topic. Uh, so this topic is very important because as anesthetists, we use a lot of we come across with patients with these drugs because now the aging population is rising, especially in the West. Uh, Most of the patients, about 50% of the old people, will end up in some sort of surgery. So at least 1 in 2 patients will come to you to the theater for any sort of intervention. So that is why it is very important to know about these antiplatelets and anticoagulants. So it's about more than 10 million deaths occur annually caused by arterial thrombotic events, especially ischemic heart disease and peripheral gangrenes. So platelets are the key prothrombotic element in arterial thrombosis, forming aggregates and interconnected by fibrin. So antiplatelet treatment can counteract this process. About 500,000 deaths are related to venous thromboembolism uh, in, in the Europe. Uh, so their uses includes the treatment of for treatment or prevention of venous thromboembolism and atrial fibrillation. For acute treatment of venous thromboembolism and during revascularization therapy, immediate acting anticoagulants are the drugs of choice to prevent or to treat these conditions. So these are the drugs that we use uh, in thromboembolic diseases: anticoagulants, fibrinolytic drugs, and antiplatelet drugs. Anticoagulants are mainly factor 10 inhibitors like heparin, and rivaroxaban. And we'll discuss more about these drugs. And factor synthesis inhibitors like oral anticoagulants, such as warfarin, and fibrinolytic drugs are streptokinase and urokinase. And also tissue type plasminogen activators, such as etaplase. Antiplatelet drugs are aspirin, dipyridamole, and uh, sulfenperazone. So we'll discuss about these drugs in detail. Okay. So this is another classification. Uh, Antiplatelets, anticoagulants, and thrombolytic agents. The same thing that I discussed with some examples. So anticoagulants, if we take, there are direct thrombin inhibitors such as dabigatran, argatroban, and lepridine. And indirect thrombin inhibitors are heparin and fondaparinux. Vitamin K epoxide reductase inhibitors are warfarin, and direct factor 10 inhibitors are rivaroxaban and apixaban. So antiplatelet drugs, cyclooxygenase inhibitors such as aspirin, and glycoprotein 2B3A receptor inhibitors are abciximab, eptifibatide, and tirofiban. ADP inhibitors are clopidogrel. So other type of drugs are thrombolytic drugs. So mainly plasminogen activators such as streptokinase, reteplase, and tenecteplase. So this is you'll know your clotting pathways. There are two pathways, intrinsic and extrinsic pathways, where your factor 10 is activated through both these pathways. So from there, your factor 2, your prothrombin is converted to thrombin, and that will convert fibrinogen to fibrin, and which makes a fibrin mesh around the platelet plaque. So if you see this is a very important diagram. This shows within a blood vessel. So this is the endothelial cell layer, and when there's a breach in the endothelium uh, of the blood vessel, this collagen is exposed, and also there's release of von Willebrand factor. So these will bind to to receptors in the platelets, and this collagen will bind to glycoprotein 1A receptor, and von Willebrand factor will bind to glycoprotein 1B receptor. So that is how they adhere platelets to the site. So when this is bound to a platelet, the platelet will get activated. So the activated platelet will degranulate these granules, which release some lot of chemicals, mainly ADP, thromboxane A2, and 5-HT. So these will go and act on other platelets. Right? They act on various receptors, and they will activate those platelets. So then those platelets also will degranulate and thereby activate more platelets. So that is how the platelet activations happen, and also this will expose this glycoprotein 2B3A receptor, which is also in the platelet membrane, and that will bind with the other platelet via a fibrinogen molecule. So this fibrinogen molecule binds to these receptors and in each of the platelets, and the platelets are bound together. That is how the uh, platelet aggregation happens. So a lot of platelets are aggregated with this process, and then at the same time, your clotting pathway is also activated. So thereby end product is prothrombin is converted to thrombin. So this will form help the fibrinogen to form fibrin. Fibrin will make a fibrin mesh around this platelet plaque, and that is how the blood clot is formed. So this is important because your drugs will act on these various receptors. Some will block these glycoprotein 1A receptors, or some will act on glycoprotein 2B3A receptors, and some drugs will prevent the ADP acting on ADP binding receptors. So that is how the antiplatelet drugs act on this uh, on various receptors, and also your other anticoagulants will act on various sides of this pathway. And there are, as you all know, naturally there will be clotting always happening inside the body, but those clots will dissolve with the naturally occurring uh, anti-clotting factors in the body. So clotting inhibitors are antithrombin. These are naturally occurring uh, anti-clotting chemicals like antithrombin, protein C. So this antithrombin will inhibit the factor 2, factor 10, and factor 9. So, and also there are naturally occurring heparin as well. So those will act via this antithrombin. So, and other anti-clotting factors are protein C, protein S will also, this protein C will inactivate factor 5 and factor 10, factor 8, and protein S is a cofactor for factor C. And tissue factor pathway inhibitors will inhibit the activity of factor 7. The plasmin will, you know, the action of plasmin will lyse the fibrin into fibrin degradating products. So that is how the natural in the body, when a clot forms, it will dissolve. If the clot forms, it will lyse by the fibrin, and the clot formation is also inhibited by various methods. So when we come to anticoagulant drugs, so indirect thrombin inhibitors are unfractionated heparin, low molecular heparin, and fondaparinux. Direct thrombin or factor 10 inhibitors also occur. Parenteral drugs are lepidolin and biveridine, and oral drugs are rivaroxaban, apixaban, edoxaban, and dabigatran. Other category is oral anticoagulants like factor synthesis inhibitors like warfarin. So unfractionated heparin, the mechanism of action is the anticoagulant effect of unfractionated heparin is mediated through binding it to the antithrombin 3. So when it binds to the antithrombin 3, it augments its action by 100 to 1,000 times. So antithrombin inhibits the action of factor 2, 9, 10, and factor 12. So this shows the action of low molecular weight heparin and unfractionated heparin. So unfractionated heparin, it binds to antithrombin 3, and it inhibits the action of thrombin and also some other factors like factor 10, factor 11, and factor 9. So when low molecular weight heparin binds to antithrombin 3, it selectively blocks only the factor 10. So when it comes to heparin, it is preferred to administer by continuous infusion. The onset of action of unfractionated heparin after subcutaneous injection is about 1 to 2 hours, and it peaks about 3 hours. So intramuscular administration should not be used because of the risk of bleeding and hematoma formation. So unfractionated heparin has a dose-dependent half-life of about 30 to 90 minutes because its elimination shows zero order kinetics. So adverse effects are bleeding, uh, and significant bone osteoporosis, and also heparin-induced thrombocytopenia. So, so what is the antidote of heparin? So when when heparin is used mainly in as anesthetics, we use a lot of heparin in vascular surgeries uh, and cardiac surgeries. Right. So when it comes to vascular surgeries, so they use about they need to uh, prevent clotting during the operation and post-operatively. So heparin is used during the surgery, and sometimes when they start closing, they start the patient due to the action of heparin, patients are still losing. So sometimes they ask us to, right, so you have given 5,000, reverse 2,000 of heparin. So, so then you should know how much protamine sulfate is used to reverse the action of heparin in these patients. So the dose is can give 1 milligram per 100 units of unfractionated heparin. Right. So it's if you use 5,000 units of heparin, the usual dose, to reverse 5,000 units of heparin, you should use about 50 milligram of protamine. So the protamine sulfate, it neutralizes heparin in about 5 minutes, and action persists about 2 hours. Right? So if accidentally, if you give high dose of heparin, it it causes bleeding, more bleeding with protamine. Okay. And the other adverse effect of heparin is bone loss when it is used more than 6 months. So other unwanted effect is heparin-induced thrombocytopenia. It is caused by antibodies that bind to complexes of heparin and platelet factor 4. These antibodies are prothrombotic and it activates platelets. Uh, and this will cause thrombotic thrombocytopenia due to platelet consumption. So this leads to arterial thrombotic events. This occurs in about 5 to 10 days after initiation of unfractionated heparin. This time is taken to produce these antibodies. If a patient develops HATE, this patient cannot take any heparin in the future, not even low molecular heparin or fondaparinux. You should use the alternative anticoagulant in this patient. So when using unfractionated heparin, two parameters require monitoring. One is APTT and other one is platelet count. This platelet count monitoring, the APTT is to see the activity of your adequacy of your anticoagulant effect with heparin, and platelet count is to see whether patient is developing heparin-induced thrombocytopenia. So APTT shouldn't increase more than 2 to 3 times normal, and not more than that, depending on the severity of the thrombosis. You should adjust the doses with the severity of the thrombosis. And other interactions are interactions with other drugs, like other anticoagulants will augment the effect, and thrombolytics, antiplatelets, all those drugs will increase the risk of bleeding. So this shows how this three drugs: unfractionated heparin, low molecular weight heparin, and fondaparinux acts. So unfractionated heparin will bind to antithrombin, and this will inhibit factor 10, and also with this long chain of the heparin uh, will directly act on factor 2 as well, thrombin. So both factor 10, thrombin, and some other few factors also inhibited. With low molecular weight heparin and fondaparinux, it acts only on factor 10. So when it comes to enoxaparin, the low molecular weight heparin, this is produced by depolymerization of unfractionated heparin, have one-third the mean unfractionated heparin molecular weight. So advantages include predictable anticoagulation dose response and improved subcutaneous bioavailability, dose-dependent elimination, and a longer half-life. So it prevents thrombus growth and propagation by enhancing the and accelerating the activity of antithrombin against factor 10. Because of smaller chain length, low molecular weight has limited activity against thrombin. So bioavailability of low molecular weight heparin is 90% after subcutaneous injection. The peak anticoagulation effect is at about 3 to 5 hours. It mainly eliminated by renal excretion. The half-life of low molecular heparin is 3 to 6 hours, and half-life may be prolonged in patients with renal impairment. So monitoring, it's a weight-based dosing of the low molecular heparin results in predictable pharmacokinetic and plasma levels in patients with normal renal functions. Therefore, uh, monitoring is not necessary in such patients. So patients with obesity, renal impairment, and pregnancy, uh, the action is unpredictable. So we need to monitor the activity of monitor the action of this low molecular heparin by determined by the anti-10A units. So peak therapeutic level should be 0.5 to 1 unit per ml for twice daily dosing, determined 4 hours after administration. So adverse effects are again bleeding, heparin-induced thrombocytopenia, and osteoporosis and osteopenia. Drug interactions are same. All the other anticoagulants, antiplatelets, and thrombolytics, they all increase the action of low molecular heparin. So fondaparinux is a synthetic molecule consisting of the active pentasaccharide unit that binds reversibly to antithrombin. It inhibits only factor 10 activity. It is effective in preventing venous thromboembolism. It is rapidly and completely absorbed through subcutaneous administration. Peak concentration is 2 hours after a single dose and 3 hours with repeated once daily dosing. It is eliminated unchanged in urine, and elimination half-life is 19 hours. So action persists for about 2 to 4 days following discontinuation of the drug in patients with normal renal function. Adverse effects are same bleeding, rare cause of HIT, and there's no antidote to reverse the antithrombotic activity. Drug interactions are same. Lepidolin is Hirudin is derived from leech, and lepuridine is from recombinant DNA technology. It's an irreversible inhibitor, inactivates fibrin-bound thrombin, used IV or subcutaneous, monitoring by APTT, eliminated by hepatic metabolism and renal excretion, accumulates in renal failure, used for thrombosis-related hit. No antidote is available to this. Bivalirudin is a direct thrombin inhibitor. It is a synthetic congener of naturally occurring anticoagulant hirudin. It is used IV. Elimination half-life is 25 minutes, cleared by hepatic and renal elimination and proteolytic cleavage. It inhibits both circulating and clot-bound thrombin reversibly. Thus, this has less bleeding risk than other R hirudins. So it also inhibits thrombin-mediated platelet activation and aggregation, used in percutaneous coronary intervention and for patients with heparin-induced thrombocytopenia. Monitored by thrombin inhibitor assay, which is better than APTT because it is not affected by antiphospholipid antibodies. It is contraindicated in severe renal impairment. So then we come to warfarin. So warfarin is an oral anticoagulant, as you all know. It is widely used. Vitamin So vitamin K in its reduced form is a required cofactor for vitamin K dependent carboxylation of factors 2, 7, 9, and 10, as well as the endogenous anticoagulant protein C and protein S, which is required for their biologic activity. So warfarin inhibits the reduction of vitamin K epoxide and reducing the formation of complete functioning clotting factors. It has no effect on preformed clotting factors. Thus, full anti-thrombotic effect is not achieved for at least 6 days after warfarin is initiated. So this shows how it acts. So it prevents this reaction, and this reduced form is, when it blocks this reaction, the vitamin K epoxide is not formed into its reduced form. So when this is reduced, the formation of this clotting factors are reduced. So the time required for warfarin to achieve its pharmacologic effect depends on the anticoagulant protein elimination half-lives. So these are the half-lives of the clotting factors. Factor 2, it's about 72 hours. Factor 7 is 6 hours. So as so on, right? Okay. So because of its narrow therapeutic index, predisposition to drug and food interactions, and exacerbation of bleeding, the warfarin requires continuous patient monitoring and education to achieve optimal outcome. So frequent monitoring, INR of monitoring is necessary. So adverse effects of bleeding. So vitamin K is the antidote and can be given parenterally or orally. The oral route is preferred in the absence of serious bleeding. In case of bleeding, warfarin should be temporarily stopped or the dose needs to be reduced. So other adverse effect is the purple toe syndrome. It is thought to be due to results of cholesterol microembolization into the arterial circulation of the toes. The next one is warfarin-induced skin necrosis. It is due to thrombosis. And in the first week of therapy, it starts as a painful maculopapular rash and ecchymosis or purpura that progresses to necrotic gangrene. So areas of the body rich in subcutaneous fat are more commonly affected: the breast, thighs, buttocks, and abdomen. The warfarin, the reaction with other drugs, the effect is increased with NSAIDs and aspirin, such as antiplatelets, and this causes GI bleeding. And clopid, it is also an antiplatelet drug. The effect is increased. Tramadol also increase the INR. Thyroxine increase the catabolism of clotting factors, thereby it increased bleeding. The vitamin K containing food supplements will reduce the effect of warfarin and it reduces the INR. So these are the other drugs that increase INR or reduce INR. These are the common drugs, as you know, enzyme inducers and enzyme inhibitors. So this cytochrome P2C9 is the hepatic microsomal enzyme responsible for metabolism of more protein S enantiomer of warfarin. Polymorphism in this enzyme, the gene, the gene which is responsible for these enzymes also will either increase or decrease the effect of warfarin. The poor metabolized subtypes have been associated with increased risk of bleeding, and warfarin resistance can be due to mutations of these genes. So depending on this activity of the gene, your action of warfarin will increase or decrease. So other type of group of drugs are direct oral anticoagulants. These drugs are nowadays commonly used in practice. Rivaroxaban, apixaban, and edoxaban. These drugs are potent and selective factor 10 inhibitors. So they do not act through antithrombin. They act directly on factor 10. So other dabigatran which is a prodrug, is a selective reversible direct factor 2 inhibitor. So these drugs are partially eliminated by the kidney to various extents and should be used with caution in patients with renal dysfunction. You need to adjust the dose in patients with altered renal functions. So terminal half-life is 10 hours for the factor 10 inhibitors and 16 hours for dabigatran. So rivaroxaban and apixaban are substrate for cytochrome P3F4 and P glycoproteins. So the its metabolism is dependent on this cytochrome P3A4, and the it, it's this glycoprotein is it facilitates the transport of the drug from the cell to the exterior. So uh, if this is activated, so more drug can be eliminated from the body. The drugs will come out from the body, the cells. So indications, the factor 10 inhibitors, rivaroxaban and apixaban, can prevent venous thromboembolism following hip or knee replacement surgery. Dabigatran and rivaroxaban and apixaban can be used for extended VTE treatment after the first 6 months of anticoagulant therapy. So this, when it comes to orthopedic trauma surgeries, a lot of patients will come with this factor 10 inhibitors like apixaban or rivaroxaban. So you should know when to operate, because uh, we are worried about giving a spinal to these patients, because these old patients will come almost all the comorbidities. So we prefer to give a spinal than a general anesthetic for them, because all these patients are very old patients with 90 to 100 years. So if we can escape with a spinal, so we are safe. So if the patients come with this apixaban and rivaroxaban, ideally we should uh, stop them for about 48 hours to give a safe spinal. So depending on your hospital protocols, you have to abide by the protocol. So the hospital that I work, we keep 48 hours of rivaroxaban or apixaban to give a safe spinal. Otherwise, we will go with a general anesthetic. So direct oral anticoagulants, the drugs that we discussed, the adverse effects are GI complications, bleeding, which ranges from minor to severe or fatal bleeding. So if such thing happens, you have to discontinue the therapy, and support to management you have to continue. Activated charcoal may be provided, because these drugs are oral drugs, so can uh, prevent the absorption, can give activated charcoal. So this drug, how do I spell that? Idarucizumab. It reverses the dabigatran action following IV administration. It binds to dabigatran, and it's like glucuronide with higher affinity than the dabigatran to thrombin. So it binds to dabigatran, and it prevents the drug binding to thrombin. So that is how it prevents the action of dabigatran. It is used in life-threatening bleeding and when there is need for urgent surgical intervention. So it is not easy when the patients come for surgeries, emergency surgeries with these drugs. There will be surgical bleeding, and it's very difficult to reverse them. And also, you can't give spinals, lot of problems with these anticoagulant drugs. So other drug interactions are same. as the other anticoagulants and antiplatelet drugs. So thrombolytic drugs, the next group is thrombolytic agents. So this diagram, if you go through carefully this diagram, this shows an atheromatous plaque when it ruptures. It causes platelet adhesion, activation, and aggregation. At the same time, it activates your clotting, right? And then your fibrin mesh is formed and the thrombus is formed within the blood vessels. So then that will prevent your blood flow and causes various problems, right? So how this fibrinolytic acts is, in the circulation, there are naturally occurring plasminogen, right? Usually plasminogen is converted to uh, plasmin, right? So if action of plasmin is to degrade these fibrin molecules and lyse the clot, right? So that is the action of fibrin. So if you can increase the amount of plasmin, you can lyse this clot easily. So if this reaction is increased by plasminogen activators like streptokinase, urokinase, and those sort of drugs, right? And at the same time, if there's excessive clotting or excessive bleeding, and if you need to prevent bleeding in surgical in certain operations, so during the surgical procedure, so if you want to prevent bleeding, if you can stabilize this clot, that also can help to prevent bleeding during operation. So in that case, you have to block this conversion of plasminogen to plasmin. So what do you use that? You know there are some drugs called commonly used drug called tranexamic acid, which blocks this reaction. The amount of plasmin is less, and the your clot will not lyse. So that is how this fibrinolytics drugs act. The thrombolytic agents are the fibrinolytic system dissolves, the same thing that I explained to you, right? Uh, so the fibrinolytic system dissolves intravascular clot by the action of plasmin, which is a protease. This will re-establish the tissue perfusion. But this is not an alternative to anticoagulants, right? It will not prevent coagulation, but it lies the clot and allow the blood to flow. But if you need to prevent further clotting, you have to use another sort of drug. So these are the thrombolytic agents: streptokinase, urokinase, and atelapase. Yeah, streptokinase is produced by Lancefield group C, beta hemolytic streptococci. It is direct. It acts indirectly. So non-enzymatic protein binds to plasminogen and induces conformation changes in and expose the active site, which convert plasminogen to plasmin. That is the action of that. And antibodies from previous streptococcal infection may neutralize the activity of this drug, and it in those patients required a loading dose, a higher dose to start with. Adverse effects are bleeding and allergic reactions, anaphylaxis, and drug fever. tissue plasminogen activators. It binds to fibrin with higher affinity and activates plasminogen bound to clot. That is fibrin selective activation. And it may activate circulating plasminogen at larger doses with longer duration of therapy. So reocclusion may occur, may be lessened by administration of another drug like heparin or antiplatelet drug. This is given by intravenous infusion. Adverse effects are bleeding and allergies. Therapeutic uses are acute myocardial infarction within 6 hours of onset, infused over 1 to 3 hours, and central DVT, severe pulmonary embolism or multiple pulmonary embolism is infused over 12 to 72 hours. Acute ischemic stroke within 3 hours of onset. Yeah, contraindications are similar to anticoagulants like excessive bleeding. Okay, antidote to thrombolytic agents, which I describe, is the aminocaproic acid and tranexamic acid. It binds to plasminogen and plasmin, thus prevent their action on fibrin. So it prevents the clot lysis. This is contraindicated in disseminated intravascular coagulation and bleeding from kidney or ureters. So adverse effects are thrombosis, myopathy, and hypotension and nausea. So then we come to the last part, is the antiplatelet drugs. So as I described, when the platelet is activated, right, what happens in the platelet from this arachidonic acid, they will produce thromboxane A2, right? For this synthesis of thromboxane A2, cyclooxygenase enzyme is needed. So this cyclooxygenase enzyme is blocked by aspirin. So this is where the aspirin acts. This thromboxane will, the action of thromboxane A2 is to express these receptors like glycoprotein 2B, 3A receptors. So this is blocked with aspirin. So then the platelet adhesion is prevented by that. So, and also when the platelet is activated, as I said, there will be releasing of a lot of chemicals. One of them is ADP. So ADP will also express the activity of these receptors. So that is blocked by ADP receptor blockers like clopidogrel and ticaprelide. So various other drugs act in various sites. Thromboxane A2 synthesis inhibitors acts here. So this receptor, which the glycoprotein 2B to 3A receptor is blocked by abciximab and tirofiban. So this will prevent binding of one platelet to another. Right? So those are the sites where these antiplatelet drugs act. So these antiplatelet drugs, these platelets provide the initial hemostatic plug at the site of vascular injury, and it participates atherosclerosis. So the drugs are used as prophylaxis for arterial thrombosis and prophylaxis and management of myocardial infarction and ischemic stroke within 2 hours of onset, and administered as adjuncts to thrombolytic therapy along with the heparin to maintain perfusion and limit the size of infarction. So the drugs, as I said, cyclooxygenase inhibitors like aspirin, PGI3 generators like icosapentaenoic acid, and ADP receptor blockers like clopidogrel and ticopridine, and glycoprotein 2B3A receptor blockers like abciximab, eptifibatide, and tirofiban, and other drugs are dipyridamole and cilesterol. So aspirin irreversibly inhibits the cyclooxygenase of platelets. It blocks the production of thromboxane A2. The effect lasts for the half-life of the platelet is about 7 to 10 days. So we use very small doses because higher doses are not beneficial because it inhibits the PGI2 production. So this drug is unsaturated fatty acid present in cold water fish. It generates PGI3 and thromboxane A3. So PGI3 is an effective anti-aggregating agent like PGI2, and thromboxane A3 is much less active than thromboxane A2. Clopidogrel and prasugrel and ticlopridine, this prevent the formation of platelet plug and clot retraction. These drugs irreversibly block the ADP P2Y2 receptor on platelets. So this will prevent binding ADP to these receptors. So it needs 4 days to work. Full effects takes a few days, about 10 days. So clopidogrel is a prodrug that requires activation via the cytochrome P450 enzyme isoform. So therapeutic uses are patients who require aspirin but who cannot take it, in myocardial infarction, unstable angina, transient ischemic attack, and ischemic stroke. And patients with coronary stents in combination with aspirin, they start with a dual therapy for a few months and then go on with a single therapy. Adverse effects are bleeding, nausea, severe neutropenia, cholestatic hepatitis, and so these are the adverse effects. Glycoprotein 2B3A receptor blockers. The receptors in this platelet function as a receptor mainly for fibrinogen and vitronectin, but also for fibronectin and 1 milliband factor. So activation of this complex is the final common pathway for platelet aggregation. So I explained how the fibrinogen molecule binds two platelets together, right? So that is prevented by this drug. It is used in acute coronary syndrome parenterally. Right? So these are the drugs in this group: abciximab, eptifibatide, and tirofiban. And the other drugs are dipyridamole and cilostazol. The dipyridamole, it is a vasodilator that also inhibits platelet function by inhibiting adenosine uptake and cyclic GMP phosphodiesterase activity. It has little or no benefit effect when it is used alone. It may be used in combination with aspirin to prevent cerebrovascular ischemia, or with warfarin to prevent prophylaxis, uh, warfarin for primary prophylaxis of thromboemboli in patients with prosthetic heart valves. Silostazol is a phosphodiesterase inhibitor that promotes vasodilatation and inhibits platelet aggregation. It is used primarily to treat intermittent claudication. So those are the drugs that uh, comes with this topic, but you need to read more about these drugs, especially with aspirin, heparin, fondaparinux, enoxaparin. So those, yeah, you should be thorough with those drugs, right? Anything else that you need to ask? Okay, I'll stop there. Yeah, it's time up for the next lecture, I think so.